The next abstract is gamma knife thalamotomy for medically refractory tremor in patients not suitable for DBS. It'll be presented today by Dr. Ali Kooshkabadi from Pittsburgh.
Thank you very much. I'd like to start off by thanking my amazing mentor, Dr. Kanzioka, for this opportunity, as well as the Academy, and an outstanding medical student at our institution, Dan Tonetti, for all his hard work. So medically refractory tremor affects approximately 5 million people in the United States and can be debilitating in prevention of daily activities of living. Years of experience and research has shown that the ventral intermediate nucleus of the thalamus is the key component of the neuronal circuit involved, as shown in this slide here. Modulation of this target has been shown to be effective in terms of tremor prevention. The three options available that neurosurgeons can provide for patients include deep brain stimulation, radiofrequency ablation, and the one that we will discuss today, gamma knife thalamotomy. And what can we do as neurosurgeons for people who are elderly, on anticoagulation, and with medical comorbidities is an important question to be asked. So in 1968, gamma knife thalamotomy was first performed in Sweden, and since then several studies have shown its effectiveness in treatment of tremor. A comparison of DBS and gamma knife thalamotomy highlights the fact that both have similar effectiveness, 70 to 90%. There is a difference, however, in the fact that DBS has the risk of open surgery and anesthesia, whereas gamma knife does not, and both have low side effect profiles. At our institution, gamma knife thalamotomy was first performed in the early 90s, and a paper earlier in 2008 analyzed 31 patients and the data at that time. Other institutions around the world will have demonstrated similar results to what I will present to you today. The demographics of the population in this current study: 51 males, 35 females, with a mean age of 71 years. 3 subgroups were also present: those with essential tremor, Parkinson's disease, and multiple sclerosis, with the according numbers and ages. So this retrospective systematic review of all patients' charts was performed using the standard grading scale for tremor, writing, and ability to drink. Documentation of follow-up scores was recorded, as well as phone interviews were performed for those who were not able to come back to clinic to see us. The standard scale for tremor is illustrated here, and the majority of our patients were in the 3 and 4 points starting off. For writing, you can see how the scale is divided, and most of our patients were either 2, 3s, or 4s. And finally, for the drinking / spilling score, most of our patients were also 2, 3, or 4. Here's an example of a clinic visit demonstrating significant problems with legible handwriting and the Archimedes spiral. Here's another example of a clinic visit showing on the left the untreated hand, and on the right the post-thalamotomy hand. So the targeting for our thalamotomy is the standard that we use for DBS, as illustrated here, and we deliver a maximum dose between 130 and 140 gray with a single 4mm isocenter. There have been some studies currently showing that the optimal target is in the posterior inferior location of the VIM, and that's where we perform our thalamotomy. Here's some imaging showing what the gamma knife lesion looks like, bright on T1 imaging, and on the right you can see evidence surrounding of perilesional gliosis. So for all of our procedures, here are the pre-op and post-op scores for writing, tremor, and drinking, showing a significant reduction in those scores after gamma knife thalamotomy. We then subdivided and analyzed the essential tremor patients, once again demonstrating significant reduction in those 3 scores. Here we have a video, if we can play that video. 1 second. So this is an 80-year-old patient seen in clinic. As you can see, the left hand is the untreated side. And now we look at her right dominant hand, which is her treated side.
Put it down. Put it down, stop.
For our Parkinson's patients, we had similar significant reductions in the 3 scores. And finally, for our multiple sclerosis patients, the one caveat with our multiple sclerosis patients, the majority started off with higher scores in all 3 categories compared to the Parkinson and essential tremor patients. Here's another illustration basically demonstrating that for the most part, the individuals pre and post-op ended up with lower scores, either 2, 1, or 0, versus their initial pre-op scores of 4 and 3. Same goes for the tremor score, and finally for the writing score. So overall, number of patients who had improvement, it's significant to note that 66% had improvement in 3 scores. Complications that we saw, an N of 4. 2 individuals had a temporary contralateral hemiparesis, and here we show the MRI imaging of the left thalamotomy lesion with the blood-brain barrier breakdown, but also the fact that subsequent imaging as well as clinical analysis, patients improved. So at the 1 year and by the 2 year mark, it was completely resolved. One patient had dysphagia after 8 months. Another had left facial numbness and perioral burning, all of which improved over time. 5 of our patients did, however, experience late tremor recurrence with a median follow-up time of 4 months, and the worsening occurred approximately at the 23-month mark. Here are those patients who had this issue, 4 of them being essential tremor patients and 1 being an MS patient. So the study limitations, this is not a randomized controlled trial on effectiveness. We did not have a control group for comparison, and some patients did not have follow-up. So in conclusion, we feel Gamma Knife is a safe and effective treatment for medically refractory tremor. The majority of our patients will benefit from this procedure with a low morbidity profile. In the future, controlled trials and studies between Gamma Knife and DBS could be performed, and we feel that radiosurgery is underutilized, especially for the aged or infirm patients with disabling tremor. Thank you very much.
Thank you, Dr. Kooshkabadi. This paper will be discussed by Dr. Isabelle Germano.
Good morning. I would like to thank the scientific committee for asking me to discuss this paper, congratulate the authors for their work. They presented 88 patients that were treated with radiosurgery thalamotomy in a 5-year period. They're all older patients with a mean age of 71 years. They report that 81% improvement was seen in at least one of the 3 tremor score that they analyzed. They had limited complications, and they conclude that a lack of control group is probably one of the limitations of this study. Let's just look at radiosurgery thalamotomy versus DBS stimulation, and the first 3 points are actually also for radiofrequency ablation. For radiosurgery thalamotomy, the improvement is not seen for a period of 6 weeks to 6 months. Electrophysiological guidance is not possible, and therefore the target is only localized by stereotactic coordinates, as the VIM is not visible on imaging. And this is different, let's say, to the STN that can be clearly seen. For the radiosurgery, there is also to keep in mind that enlarging lesions will develop, and they can cause delayed neurological deficits. And this was seen in 4 patients in these studies. 3 had hemiparesis or facial problems, and 1 had dysphagia. And all of those occurred within 8 to 6 months after the procedure, which is not uncommon for radiosurgery. We also see that for other diseases. Additionally, although these authors did not comment on this, but other studies, in particular Dr. Young's study, showed that there is a decreased effect over time. In his studies, there were 172 patients, and whereas at 1 year, 92% were tremor-free, at 4 years, 88 remained. Additionally, as they said, there was another study that they reported in 2008, and the improvement then was 92% with a follow-up that was slightly longer, 36 months, and an N that was equal to 26. Now we have a greater N, and the improvement is 81, and yet the follow-up is shorter. And the scores that were observed were different. Tremor and writing was the 2 scores in 2008, and now we have tremor, writing, and drinking, spilling. So we conclude that probably effort to standardize the outcome should be achieved. Looking at comparison with DBS, there is one Class 1 study that was done with 13 patients, and the side effects of thalamotomy were 50% as opposed to 14% for DBS. Another study with an open label, the side effects of thalamotomy were 88% and only 41% for the DBS. So we conclude by saying that we congratulate the authors for their work, that as we move forward, efforts to standardize the outcome measure should be made, and that comparative studies with DBS might be difficult and perhaps not even pertinent, because what we're looking at here is a palliative treatment for a population of patients that cannot undergo surgery. Thank you very much.